So the broadcast just started, our recording part, but we're going to hold off and begin the actual presentation in a few minutes, right at the 10 o'clock hour. But in the meantime, if anybody has any questions, you can go ahead and put that in the question panel. We'll see what we can do to help you out. Hey, everybody, welcome. We're glad to have you here. We're going to start in just a few minutes. Sorry, we don't have like Jeopardy music in the background. Hello, everyone. We're going to go ahead and get started. Thank you for joining us today. We are really pleased to be able to co-sponsor this webinar with United Way Worldwide, featuring this conversation around COVID-19 response and operations. In a moment, I'm going to go through some of the technical things you need to know, but first, I really want to take the opportunity to express on behalf of the AIR staff how honored we are to be part of a network of extraordinary people who do extraordinary things in their communities every day. And this recent crisis and the willingness of this group to step up and do what needs to be done is just another manifestation of your passion and commitment. And we wanted you to know that it doesn't go unnoticed. And we see you, and we are grateful for that commitment that you give, and thank you. So we're actually going to go over a few items really quick on how to participate today. You should be able to see a slide that was just pulled up where there's a screenshot of the attendee interface. You should see something that looks like this on your own computer desktop in the upper right-hand corner. You're listening in using your computer speaker system by default. If you would prefer to join over the phone, just select telephone in the audio pane and the dial-in information will be displayed. During the presentation, the control panel may sometimes get in the way of some of the screens, in which case there is an orange hide control panel button on the top left-hand corner of the control panel. Clicking that will push the panel to the side, and clicking it again will bring it back up. So just a reminder that the audio in this presentation just goes one way. You can hear us, but we can't hear you. This includes all the organizers and panelists. However, on your control panel, you will see that you can type questions to the presenters. You may send in your questions at any time during the presentation. We'll be collecting these and addressing them during the Q&A session at the end of today's presentation, or we'll answer them during the presentation via that chat box, or if we don't get to them, we'll make sure that we connect via email to the appropriate panelist in order to be able to answer that right question. We also want to point out today that usually there's webinars. We're pretty good about ending right on the hour or before. Today, we will be hanging out a little bit longer just to make sure that all the questions are answered. So feel free to ask as many questions as you feel is appropriate, and we will do all that we can to make sure that those needs are being met. So a recording of today's presentation is going to be available to you. It will be sent out 1 hour after the event via an email. This recording will also be available on our YouTube channel, which is Airs Place, later today, as well as on the Airs Learn site. That recording will also include a downloadable version of the presentation we'll be using today. If you think of any questions after the presentation is over, please feel free to email myself or Josh Patterson, whose emails you see here, and we will do what we can to get your questions answered. So we are going to do a little introductions just really quick, not of all the panelists. We have a lot of that going on, but Josh and I are going to be facilitating together today. So we're going to pop on with our webcams to say hi, make sure you know that we're here with you. We're both joining you from we have people joining you almost literally from coast to coast today, from the California, Pacific Coast, all the way over to Washington, D.C., Maryland, that area over Connecticut, all of those. And so we are really glad to be here with all of you today. So I'm actually at this point, Josh and I, like I said, are going to stay here with the webcams, but I am going to give the presentation over to Josh, who is going to begin the meat of why you came here today. All right, Josh, it's all to you.
Awesome. Thank you so much. And I appreciate AIRS helping host and pull together this entire webinar. We have a fantastic group of panelists available today, and they pulled together this presentation on such short notice, and I can't thank them enough. Rachel Krausman is joining us from United Way Worldwide, Tanya Barrett, and Elena Krober from Connecticut 211, Kelly Brown and Yasmin Alif from 211 Ventura, and Damon Terzaghi from Advancing States, which is one of our AIRS partners in the Aging and Disabilities Network. Tim Sullivan wishes he could join us. He got pulled away at the last minute for a phone call. So we miss him, but know that he's busy working in the state of Washington. Just as a quick welcome before I turn the time over to Rachel, one of the hardest things that we deal with in our network, of course, is responding to inquiries where we may not have an answer. It can be very taxing when the problems tend to outweigh the different resources, but one of the best things about our network is that we can often offer hope and some solutions and brainstorm and be creative and be a safety net for so many people that need help. And I feel like that is that same scenario we're in right now, where there is a lot of information that we're struggling to find resources on, but at the same time, we have an entire amazing network across the entire country within our aging and disabilities community, with our 211 community across a wide spectrum of call centers that are handling crisis and health calls, some activated, some not activated, but all of us bring a wealth of expertise to our network. And that is the coolest thing about our network is that coming together. It's the best part of any movie or TV show when we all root together and come together for the team or the underdog or somebody at the end of the movie, and we all cheer and support everybody at the end. And I see that happening day to day in our network is groups pulling in. We've seen it time and time during past natural disasters, but this is another instance of that as well. So I'm going to turn the time over to Rachel Crossman. We have a packed agenda today, so we'll zip through this content in a somewhat brisk way, but there's a lot of relevant content that we're sharing, and we will make it available online, as Kiara talked about, after the presentation. So Rachel, turn the time over to you.
Rachel, are you there?
And I think, Kiara, maybe you can unmute Rachel, if that's possible.
I did.
Okay.
Okay. Can you hear me now?
There we go. Yeah,
Sweet.
there we go.
Excellent. Thanks, guys. Hi, everyone. Just echoing first what Kiara and Josh both shared. Thank you for hopping on this webinar with very short notice, and a special thank you to the folks who are not only handling a response right now, but joined us to share some of what they've learned so far. I'm going to jump in and just do a little bit of a level set with this situation as it is currently, and answer proactively a couple of the common questions that we have been getting here at Worldwide, and then turn it over for the rest of the webinar to the actual experts on the ground. So Josh, will you move ahead? Awesome. So for folks who are not as familiar yet with what we're actually referring to, this slide contains a number of key points. Coronavirus, which you're more commonly seeing now referred to as COVID-19, that stands for coronavirus, and then refers to the specific outbreak that started in 2019. It is a new disease, so it's caused by a novel virus that hasn't been previously seen in humans, which is part of what has caused some of the concern, we might call it panic, and the widespread. This is because there is not a vaccine for this virus yet. There aren't treatments available for the virus yet, because it is this novel or new strain of a virus. However, it does cause symptoms that are very similar to the common cold or seasonal flu. So the most common symptoms that people are experiencing are fever, cough, shortness of breath. For those that are experiencing severe illness, it moves into more of a respiratory infection, which is why it becomes more severe. But one of the key points, and one of the reasons there's a lot of public information dissemination happening, and where 211s are starting to come into the picture, is because the symptoms are so similar to common illnesses that do have treatments and vaccines available. And the only way to really know whether someone is infected with COVID-19 versus the flu is to actually get a test. In terms of high risk, there's been a lot of conversation about risk. Obviously, typically people who are healthy and don't have underlying medical conditions, are not older adults, are recovering fine. That doesn't mean this isn't of concern and isn't dangerous, but the high-risk population really is right now folks who are older adults, which is why I'm so glad we have our friends from the aging and disabilities community on, and those who have some type of underlying chronic medical condition, particularly affecting the heart, lung, or kidneys. There is not actually currently data to suggest that young children are at higher risk. So this is a little bit of a departure from seasonal flu, where kids under the age of 2 are at higher risk. But there is some data to suggest that kids are carriers because they're not actually experiencing symptoms but may be spreading the disease. Again, very, very early stages of having data on that, which is why you're not seeing any type of extreme measure around children and shutting down schools and things like that yet. We just want to ground some of that information. In terms of how the virus spreads, again, it spreads very similar to something like flu. It spreads through respiratory droplets, which is basically when you cough or sneeze, and why we need folks to cover their mouths and noses when they cough and sneeze and wash their hands thoroughly, very frequently. Though people are, we think, most contagious when they are actually feeling sick and experiencing symptoms, it is possible that the virus is spreading before symptoms present, which is another reason that people are being asked to be more cautious, to not only wait to take precautionary measures like washing their hands when they feel sick, but everyone doing so ahead of time, because the virus may be spreading before you even know that you're ill. There's also some early data about spread on surfaces. So the CDC and epidemiologists are working on determining how long the virus can actually live on a surface versus a human or in an animal. But again, this is why you're seeing a lot of disinfecting happening in subways and buildings and common areas, because it can live to some extent on those surfaces. Right now, there are confirmed cases in over 100 countries. Most countries have very few cases still. Obviously, this started in China, but it has spread pretty far at this point. So it is not, certainly not restricted to any specific type of country or society. It's spreading pretty quickly across the globe. Next slide, Josh. In the US specifically, you will see a lot of different numbers coming from a lot of different sources. Part of the challenge right now is that, like I said, the only real way to know if someone is actually sick with COVID versus a different virus is if they get a test. The testing is happening, but it is not necessarily happening very quickly and everywhere all the time. So as of yesterday, the CDC posted that there were 647 confirmed cases in the US. There have been posts that were over 1,000 confirmed cases as of today, but that hasn't been totally confirmed and published by the CDC yet. Regardless, there are confirmed cases in most states now, including the District of Columbia, though most of those states have fewer than 20 cases, with the exception of places you've likely heard about on the news and who we have represented on the call today. So Washington, obviously there's a major outbreak in the Seattle area, California, and then New York, with the most recent news about Westchester County and some of the surrounding areas there.
Rachel? Rachel,
Yeah.
before you move on to the other points, I was just going to see if you happen to know in your conversations with the CDC, we have two questions that have come through. Otherwise, I'll start doing some research. One is, do they know how it got started in the Wuhan process, in the Wuhan province? Is there any information on the CDC site that speaks to that at all?
Most of the information right now is still a little bit vague unless you want to go deep into sort of the science of the virus. It did start in an animal, and it was originally thought to just be spread animal to animal, but then obviously there was a confirmed case in a human, and then sort of transmission spread from there. The way that novel viruses start in the first place is sort of the same way that we understand evolution to happen. So viruses evolve and create sort of novel viruses, which is why we're always worried about a flu pandemic, for example, which would be a variation on a seasonal flu virus. I don't want to say too much more because I am not actually a public health expert, but that's generally what we understand at this point.
Okay, so things like symptoms, variations of symptoms, would that all be on the CDC website that you've shared right there?
Yes. So the CDC website, and there are live links on the 211.org COVID page, which might be easiest for people to access, has extensive information about symptoms, risk, how to prevent the spread, as well as the link right here is specific to a page about the outbreak in the US. So there's a map and data by state in terms of where confirmed cases are at this point.
Okay, I think we'll pause the questions there, and we'll have you keep going with these bullets, and then we'll come back and address things as we need to. Thanks, Rachel.
Okay, sure, sounds good. So the next three are just, again, things that probably folks have heard about in the news but wanted to sort of confirm based on the actual information from CDC. So there is a request for folks who are returning to the US from certain countries that they self-quarantine for 14 days. There are likely to be new countries added to this list in the next couple of weeks as the virus spreads. So this is just, again, precautionary measures that you may hear about from folks who are coming back from abroad. Obviously, a large number of conferences and events have been canceled. Worldwide recently announced that we canceled one of our upcoming events. Most of this is happening just out of an abundance of caution to help prevent the spread, not because there should be public panic about a pandemic yet. Just, again, that we're trying to keep germs at bay and keep people home in their communities. Similarly, there's a small number of schools and school districts that are closing schools. Largely, they're closing them temporarily in order to do a deep cleaning and disinfect after someone in the school has either been confirmed with a case or confirmed to have been in contact with someone who was confirmed. So it's not that schools are closing sort of indefinitely in perpetuity. It's more of a temporary closure so that the school can be cleaned, people can be tested, and then schools anticipate reopening. Next slide. You'll hear more about, obviously, the 211 response on the rest of this call, but wanted to share some high-level information. We asked 211s to tell us via a survey how they're responding. I will start by saying this is probably not an exhaustive list because there are probably 211s out there who just haven't told us yet, but we are aware at least of 9 states that have been officially activated and to whom the public is being referred for information by local and state officials. Then there are additional more local or regional 211s that are similarly part of activations and or at the very least, people are being directed to them. You've probably seen some communication from both AIRS and United Way Worldwide, simply recommending A, take care of yourselves and your staff, but B, to the extent that you're able to have folks work remotely, not necessarily necessary yet everywhere, but start to really think about that. Again, folks will talk more about that later in this webinar. And then lastly, we have created a COVID response group specifically on the workplace site that we manage from the worldwide side. We're happy to add folks to that if you are part of an active response. It's very tactical and operational, so we're trying to really keep it focused on sharing information and resources in a pretty rapid fashion. And then this is my last slide. So the flu on call information I want to provide because we are getting a lot of questions from folks in the network. So again, this is sort of just grounding information, hopefully to answer some of those commonly asked questions. Either because you're part of flu on call or simply because you've heard about it in the network for the past couple of years, you may be aware that we have a contract with the CDC for a program called Flu on Call. This is essentially a contract to build a system that could be activated in response to a flu pandemic specifically through a number of different tools that includes a sort of line of information specialists, which is where we've engaged 211s in the past. So to provide answers to commonly asked questions, disseminate information, not dissimilar from what many of you are currently doing for COVID. This contract is a 5-year contract, so we are in the last year right now, so it's still active. At this time, we are working with the CDC to tweak and change some of the tools to be relevant to COVID instead of flu, so that some of the system can be activated if the CDC decides it's necessary to activate. The focus by the CDC, though, is on all of the different technology-enabled tools with the hope that we don't have to actually activate people to respond. So we're focusing on a self-assessment that asks people a bunch of questions about symptoms and travel and then tells them what they should do. Automated texting campaigns that does something similar. And then the kind of next level of activation or support would be to actually engage medical professionals who can provide medical advice and triage calls from that standpoint. Though we have engaged 211s in this program over the past 5 years, right now there is no plan to activate any of the 211s as part of activating this system for COVID. If that changes, the 211s who have been part of Flu on Call will be the first to know, but right now this is the status. If the system is activated, its intent is to augment local and state efforts to provide information to the public. So this will be something that is layered on top of stuff that is already happening locally and at a state level. It would enable you and your partners to direct people to another resource offered directly from the CDC to answer questions or get medical advice. But each state is empowered to decide whether they direct people to Flu on Call in their state. In other words, it's up to the localities to sort of decide what to do with it. But again, it is not currently active, and we are therefore not promoting it or talking about it publicly, and would ask 211s to not do so either. That's the end of my section. Kiara, Josh, I'm happy to answer questions or simply hold until the end so we can bounce to other folks.
So looking at the questions we have right now, let me just double check. Really the best things, since we really want to focus on operations, is there's a lot of questions about symptoms and things like that. The CDC link that I sent out to everybody that will also be included in the follow-up email is your best source and the same source that Rachel is actually using. So they're going to be able to give you that as far as symptoms and testing and how it can be passed on. Again, same resource source as Rachel. I also Sawyer sent and shared that. Sawyer sent and shared how your 211 is responding to COVID-19 survey, and I included that in the chat section as well, so everybody can add that. And then I think anything else, Josh, do you see any other questions that I'm missing that would be relevant for Rachel at this time? Okay, so let's Rachel, are we okay to volley it back to Josh and we'll move from there?
Yep. Absolutely.
Okay, great.
Great. Awesome. Thank you so much, Rachel. We'll turn the time over to Tanya Barrett now, who, as Rachel mentioned, leads the Connecticut 211, and they have been activated by their state. Tanya.
Hello. Good afternoon. I am talking to you all live from our state emergency operations center. Like Josh and Rachel indicated, we have been activated by our state emergency framework for COVID-19 response since Friday. The EOC is currently being staffed Monday through Friday from 8 to 4:30. There is a regular cadence of information and calls. 211 has been identified as the hotline for public information dissemination as well as rumor control. And we're working closely with all the state agencies, with DPH being the lead, to escalate issues and to provide important messaging that needs to be included in press releases, online and through social media. So far, we have set up several different channels that can be accessed through an agreement with our Department of Public Health. And the messaging is all provided and approved by DPH. And then we offer it both by live answer, by pre-recorded IVR messaging, by automated text response, and we also have information available on our website through the search engine, as well as a big banner that directs folks to the state's official website for COVID-19. The official website is actually our state ct.gov coronavirus website. It is not the 211 site, so we have to be, really careful about the messaging there, and that's in an effort to make sure that there is really only one point of contact for the web information. So,
Tanya,
go ahead.
we have a good question that would be applicable right now, I believe. What does it mean? This is from Leland. And what does it mean for a 211 center to be activated? Does that mean that local INR programs should direct coronavirus questions to 211? Also, how will those of us who live in states where 211 has not yet been activated hear that 211 has been activated in our state?
Yeah, so I think, activation can mean different things in different states. I think most 211s are, if you're not formally activated by your state agency, you're being activated by the public calls that you're getting on this anyways. In Connecticut, we have a formal role in the state emergency management framework, not just for COVID, it's also for weather emergencies, health emergencies, and mass casualty events. So this is something that we do year round, and it's important, during non-emergency times to really develop the relationships with your state Homeland Security and emergency management, as well as your state agency officials, so that they know what you can do should there be an emergency, and that they know how to contact you and what type of capacity you would have. Does
Okay.
that answer it?
I think so. There's some questions that come after that I think is important. The second one is there a funding component with your agreement with the state? How do you secure that? And how do you calculate that? And I think that's applicable not just for 211s, but anyone who might be any INR who's supporting a local entity, perhaps. How do you cover that?
Yeah, so there is a funding component for this, and it's not always the case, but in this instance, we did put together a scope and send that off to DPH, the lead agency, and letting them know how much it was going to cost us to offer all of the channels that I mentioned. We also knew that we would have to get temporary staffing in, so they were willing to cover the cost, as there is some dollars around preparedness, and then specifically for COVID-19 that will be coming to the state. I want to just be clear that that's not always the case, but again, because whether you're activated formally or informally, just by people calling you, you have to be prepared to handle the calls in some way. And so, we would do that regardless of the funding, just because people would be calling us. But I think it's never a bad idea to connect with your lead agency, let them know what you're doing, especially if it is something where you're incurring additional costs that you would not have otherwise, because sometimes there can be funding.
So I think what I'm hearing is that even if you don't have funds available now, which usually happens in like a pre-made agreement with the government entity, something that you can do is monitor or track is probably the word I'm looking for, the cost that you are incurring at the time. And then if there are funds that become available to help reimburse different organizations for their efforts, that if you have the information that you could turn in, that there could possibly be some reimbursement involved with that afterward. So you're not recommending, if you don't have a funding agreement, to just not respond, right? Just do what you can.
Yeah. I think,
Okay.
I think the scope of this this flu outbreak, pandemic, I guess they are calling it, right? I'm always very careful with that word. But I think because of the scope of it, there's no avoiding questions to your 211. And I think you can be, strategic about what type of capacity and channels you're offering based on, what your underlying structure is and what you can handle without taking on too much that you're overwhelmed. So, one of the things is that we did was we definitely wanted to have pre-recorded messages up and ready, really to make sure that those calls that could be answered with just general information that did not need to speak to a live 211 contact specialist could be handled. And with the exception of yesterday, most days the pre-recorded messages are more heavily utilized than the live answer 211 contact specialist.
So
yesterday, the state declared a public health emergency and a civil preparedness response in Connecticut. So that was the only exception to that.
So there's a couple questions that we have that are popping up about some of the tools that you've used. I think if it's all right, I'm going to connect like templates and tools. I'm going to go ahead and connect them with you after to bring that conversation to a place where we can kind of share some of those things. Is that okay?
Sure.
Okay, let's do that. And then for everyone else too, Josh, are we going to address kind of the elevation? We've had several questions. I know that we're also going to hear from Kelly and a few other people. Are we going to be addressing how people have experienced an elevation in calls later?
So a couple things, and Kelly's going to address some of those messages as well. So thank you, Tanya, for being available to answer some of those follow-up questions about what messages you're having in your IVR and what you're automating. And that's exactly what Kelly's going to talk about next. So we're going to turn the time over to Kelly. And then as far as elevation and managing the call surge, I think that's again, something that Kelly's going to address to a degree, but it's also going to definitely be a challenge and something that, as Tanya pointed out, you've got to have that relationship with your state health department or your state emergency operations center to determine what kind of relationship you're going to have as you maybe take on the burden of additional calls. We know that oftentimes the calls may not even be associated with the virus itself, but are going to be associated with lost wages or childcare, and that's what we do every day in our routine business. And so we may see an influx of calls in the coming months as well. So employing some of these new tactics, like Kelly's going to talk about, I think can help us be more efficient in that.
Yeah. So really quick, let me clarify. The question was about a template of a scope of work to propose to an organization that you're trying to make a relationship with, and then also tracking tools for how to make sure that you're tracking the volume of calls and the cost of that. So that is that okay to take that offline? So turn to Kelly for this other piece about the operational, but we're okay to take that other one into a different space.
Yeah. Unless you had anything quick to add there, Tanya.
The only thing, since I've had a few minutes to think about it, because we are in the middle of a response, is it possible that, Josh, we could provide the scope template to you? I mean, it's going to be different for every 211, but in retrospect, that was a bad idea to get individual emails to me.
Okay. Yeah, I think using Josh as a repository, I think that's great.
Yep, we'll post that on Workplace, and we've I think Tim Sullivan from Washington has already shared some of his scope of work with a couple other states. So we'll post that content on Workplace so everybody has access to it as well. So
we'll put it out on the
network.
network.
Thank you, Tanya. Yeah, very cool. All right, we'll turn the time over now to Kelly Brown and Yasmin Ali. Thank you so much, Kelly and Yasmin, for your help in this. We, anytime there's a disaster that comes up, I can always count on a text message or email from Kelly saying, hey, we're here to help, we're here to help. She's definitely one of the backbones of our response effort and knows how to do it right. So we'll turn the time over to Kelly for a few minutes here, and she's got a couple slides to share about what they're doing in their particular call center in Ventura. Kelly.
Great. Will I be able to move the slides or will you move them? Are you there? Can you hear me?
Yep.
Okay, great.
Yeah.
Awesome.
Yeah,
So I wanted to talk a little bit about our response here in California. So our 211 does serve several counties of California. I think we're at about 30 counties right now total. Some of those are disaster only counties, which technically this is now becoming a disaster for California here. So we are activated by some of the counties right now. I think 5 counties now have officially activated 211 as their call center for coronavirus. So before we got activated, we started thinking about planning for what we knew was going to be coming over the next few weeks. And we decided to get some ideas of how we can divert from live calls. And so what I wanted to talk to you about today was how to divert from live call handling, because I don't know of any 211 that can handle 500-600 calls coming in at once. So we want to try to get the information out to all of the people that are contacting us, even if it means it's hundreds and hundreds at one time. We want to make sure that we're answering that and not just having them drop out of the queue because we can't get to them. So the first suggestion that I wanted to talk about was recorded information on your IVR system in the phone system. So Tanya Barrett was talking about using that as well. So we do have several recorded coronavirus messages that we recorded in English, Spanish, and Cantonese. We are currently thinking of other languages to have those recorded in this week so that it can be available to all of the different communities that are contacting us for information. Those recordings are available. If you would like to use them, you are welcome. If you don't want to make them yourself, I can give those over to anyone who might be interested in those. The thing that about using recorded information is that you can control the content of what people are talking about. And we all love our staff and they are really amazing, but under stress, people sometimes can kind of go off on a tangent sometimes and end up talking about something that you wouldn't want them talking about because people are upset and talking to them. They think they have coronavirus, they're sick, they're coughing, and then you could end up having a personal conversation easily in that because you really want to help somebody and connect with them. So giving people controlled information in a recording, I think is a really good option for helping staff to not have that happen to them. The other thing about using recorded messages is you can have several people in the queue listening to those at one time. So I did want to talk about a little bit about increasing your port usage if you're in your phone system. So you will want to contact, if you're going to get activated, you will want to contact and increase your ports because if you have 50 ports available to you or something like that, should 500 people call you, they're going to get the fast busy, right? So you want to increase the ports. If you are in contact, you can actually increase your ports up to 500 per day without a special order. So you may want to just, send them an email to your account manager and ask them to increase your ports to 500. And then the next day you can do the same thing. It really just depends on how many calls you're okay with being in the queue at once. So I would just think about that closely because you would be paying for the per minutes while they are listening. So create a set of messages with the information that is most being asked. So it's really great, use your call form to figure out what questions are people asking you. So we have a call type, disaster, public health, and then a bunch of different reasons. And I'll show you that in a minute. And so you can be tracking those reasons and every morning pull that report from your database and say, what are people calling us about? Try to get that into a recorded message that people can hear so that your agents are available for live calls, but available for live calls for people who don't have access to the internet or need help reading. So, sorry, next slide, thank you. So I did create with United Way California a auto text campaign for coronavirus. And this text campaign, I did not check this morning, but it was over 6,000 active users in California as of, and one county in Illinois as of this morning. So this is a way to give out information, again, controlled information via text message to people 24/7. And should those 6,000 people have called us, we would have definitely drowned. So I'm very glad that they've been using our text campaign. So the text campaign gives links to all of the CDC websites up front, and It has general information that people are asking about. And then if you text in your zip code, you can have county specific information. I have it there in the middle. There is a example of that. So the original message is up front. Then I put in my personal zip code, and Ventura County specific messaging comes back. And those messages can be added by county and change daily. And I would suggest, working with your local public health office to figure out what kind of information needs to go out in your county, at that time. You can also use your system to send out push messages to people. So if something like the little smaller example I have there, so it's about the county of Santa Clara yesterday, and this is a real thing. Yesterday, Santa Clara County, which is where San Jose, California is, if you're not familiar, did issue a mass gatherings cancel. It's a mandatory order to actually cancel all mass gatherings of people over 1,000 attendees in all of Santa Clara County for the next 3 weeks. So you can send out push messages to everyone who's contacted you via phone or text and tell them updates, so that people are not flooding you with calls asking you about something that they heard. So you can just send it to them first so that they don't have to call you to get that information. I do suggest using a keyword with an opt-in, and remember to give people the option to opt out as well. Developing, if you have a short code, great, use the short code. If you have access to a short code, use that, because that's easier for people. But if not, and you have a system that uses a 10-digit number, that's fine too. So if you have questions about how to do that, or you want to talk to me more about auto text campaign, you can reach out to me anytime. I'm available. So I do highly suggest using text. People like it, people want to use it, and it has kept us here from drowning in California in thousands and thousands of calls.
Kelly, we have an important question that's come up. How are you handling the reporting deliverables when you're using IVR and text messaging?
For reporting for IVR, we are looking at how many calls came into the pre-queue state, and then listened to the messaging, and then hung up before and did not ask for an agent. So our messaging at the end says, if you would like to speak to an agent after listening to all the messaging, press 4. If they don't do that and they hang up, then we are realizing that they listened to all the messaging and then disconnected. If they did go across and talk to a person, then we can see that in our reporting that they requested an agent and talked to someone. The average call length when we're talking to someone right now is 8 to 10 minutes, talking about coronavirus. And was about 75% of the callers are listening to the messaging and hanging up, with 25% of the callers coming through.
What about with text messaging?
So reporting with text messaging with the text platform that I use, I have a little dashboard that it automatically pops up, and I can see how many people are texting me and what county they're texting from. I can actually see by time as well, and there's some really interesting stuff in there, because I'm finding that people are texting us in waves at 2 and 3 a.m. and stuff like that. So I don't know where they're seeing it. I think that people are pushing it out via social media and Twitter. I've seen it on social media for cities and county sites. So I think when stuff gets updated in certain places, people are just flooding and looking at it and start texting in. So it's kind of cool to see the times. And God forbid I were to get 200 to 300 calls at 2 o'clock in the morning. That would be devastating here. Personally, I don't know what your overnight staffing looks like, but it's pretty slim here. So that would be really bad for our call center. So really glad that people had chose text over a live call at that time.
So let me just clarify. So you're saying 75% are listening to the messaging and then hanging up. Is that right? So 25% are making it through to a...
So 25% are saying, yes, I'd like to speak to an agent still. Mm-hmm.
You should also know that we've just had a request for you to do a webinar or other air session on not being afraid of your IVR. So just be prepared. I'll be reaching. I'll find you, Kelly. I'll find you. It'll be good.
Yep. No problem.
And I just want to add something here. In addition, and Tanya didn't get a chance to talk about it, but Connecticut is also set up their 898-211 or their short code to also respond via text messaging. So
Great.
I think it's being done in multiple ways, like you said, using a keyword, using easy opt-ins, and then sending out your information depending on your unique system that you manage. So this is all very cool stuff, and I think a very efficient way to deliver services, and it's a great way. So thank you.
And the messaging is pretty universal, right? So if people are interested in looking at the messaging templates that we have, then I can share those as well. If you're trying to build your own campaign, I'm glad to share that with you.
There's definitely an interest in that.
Mm-hmm. All right, so then the next thing that we did was we created these social media templates. These are blank templates here. So just showing you some examples of how to have a consistent look for the coronavirus messaging that's going out. Most of the messaging really is telling people to text in to the text campaign that you have or listen to the messaging, but you can also send out messages here about what to do if you get sick. You can have that in here, and then what to do or when to seek medical attention, all of the questions that are coming up most often. I even have some for what is my pet in danger of getting sick, so that you can send these out to people with messaging so they understand that, one, whatever message you're sending to them, but also they can see that it's coming from 211 and know that you're a source of other information should they need. So I developed these with my team, some really awesome templates so that we can send those out across California, and when people see that, they know that this is a 211. And I think the next slide, no, that's great. Yeah, so those are a couple of examples. So I wanted to talk a little bit about live call handling. So live call handling here is going kind of slow, and that's what we were hoping for. It seems as though our text messaging and our recorded messages are really helping to give the information people need, and then leaving my staff available to talk to those that are most vulnerable and not able to use those kind of automatic options. So we are able to handle at this time our call handling, our call volume, but we are very aware that that could change at any time. Even this morning, we learned that the TSA in San Jose International Airport, that there were 3 TSA agents that tested positive. We're realizing that news like that could really cause people to get quite upset and very even panic. So we know that at any time we could get a wave of people who just want to talk to somebody and get information about something that we do not have to send out. So we are trying to prepare by staffing up, having higher staff level at the call center, and I'm even bringing in some extra people that from other departments that used to work for us to come in and train on this just in case I need them. And then I would say that the level 3 for us, so level 1 is just my own staff, extra time. Level 2 is bringing in additional staff that used to work for 211 but now are working in other parts of the agency. And then my level 3 would be developing cohorts of volunteer teams that are in the different counties that I serve, and then training them to take calls for coronavirus in their own county. So maybe 5 or 6 pods around California of 5 to 10 volunteers that can help us to take calls. So that's sort of the level 3. I would say level 4 is something that all of us should consider. So should your 211 end up with getting 5,000 calls a day, whether you're activated or not, it's something that you're going to have to deal with. So if you feel like there is a possibility that you're having a major outbreak in your area, I would highly suggest practicing rollover with another partner 211. So I highly suggest trying that at a very low call volume time, 5 o'clock in the morning on a Saturday or something, and roll calls between each other and just see how it works so you can understand if you can actually do it or not. I have had times where I tried to do it in the middle of a disaster at 2 o'clock in the morning, and it is much harder to try to do stuff like that. The other thing I would suggest for live call handling is if you don't have remote agents already or you haven't tried it, what I'm going to be doing this week is I'm going to find 5 key staff people that I'm going to try working remotely from home for a week and see what kind of issues we run into, whether it's internet, systems, just productivity issues, whatever it might be. I want to sort of get a little pilot test of having some people work from home, just in case I have in my county a mandate come down that any workers that can work remote need to work remote. And I know that has happened to some 211s already. So I just want to be prepared. So if there's some kind of experiments you can do like that, seeing if your staff can work from home, what kind of equipment they need, how to make it happen, I would suggest testing that. Yesterday, the other thing I did that I think could be helpful for managers and supervisors is I put myself on a Zoom meeting, and I just had a Zoom meeting all day. So it was an 8-hour Zoom yesterday, and I just left myself on just like I'm with you now. And if people wanted to jump on and ask me a question, or we needed to work on something together, we worked on it together via Zoom, even though we're all in the same office. So that's sort of my beginning of social distancing and testing working on Zoom via remote in case I end up having to be at my house someday doing work. So that worked really well. I really was happy with me and Yasmin, who's behind me. Sorry, I didn't introduce Yasmin Ali, who has been my COVID-19 specialist and doing so much amazing work on the texting and the IVR messaging and every single thing. So she's really been helping me a lot. And yesterday we did a lot of really cool work via Zoom together, even though she was right down the hallway from me. So tips for preparing your staff is the most important thing to me is that you understand the content yourself, because if you're going in and you don't really know what you're trying to say to them, they're going to know that right away. So really go through and understand what it is you're asking them to do. What kind of content are you trying to have them learn? What is the answer about when somebody should get medical attention, when someone should stay home from work, when somebody, go through that information and feel fairly confident in what those answers are, because your staff are going to want to know how to answer that, and you want to make sure that they know that you know what you're talking about. So also the rest of your admin team, even people who don't take calls, you should make sure that they feel confident with what's going on in your call center. If you feel like you're going to end up doing live call handling, everybody needs to be all hands on deck. You need to understand what's happening and what needs to be done in your call center. So then present those training materials in several different formats, because people learn differently. So I would suggest we have video recordings that our public health departments around the state have actually made for us. So when they do their own staff trainings, I'm asking them to record those so that my staff can watch it later. Of course, we have 24/7 staff, so a 10 a.m. training from someone is not helpful for that. So at 10 a.m. we're very busy too. So recording it and then having it where people can watch it at different times is great. And if you can take little groups off so that they can watch it together and talk about it, and you can answer questions they might have, even better. One-on-one training is really important too. Just asking if people feel comfortable. Is there something else I can do to help you to understand what we're doing today? And then, those group video meetings like I talked, a panel discussion, if you have time for something cool like that, to bring in some people that are experts that can help people to really feel like they know what they're talking about. Some public health people coming in, that would be like really amazing. And if you could do that via Zoom, even better. I do highly suggest working with public health to make sure that the information that you're giving out is what they want you to give out. It's going to make you have a closer relationship with public health, and it's going to help you to make sure that you're telling people the right things and that you're getting information as quickly as possible from public health if there's a major change like a quarantine or something like that. Make sure that you're giving the same level of training to every shift. I don't know if this is just me. I hope it's not. But a lot of times when I roll out something new, my overnight staff do not get as good of a training as my evening or as my day staff, and sometimes my late evening staff too. I feel like I might get a little bit lazy when it comes to making sure that they have the materials that they need. I'll send them things to read, but I never, I don't want to say never, but sometimes I don't take the time to come in and talk to them in person. So I do highly suggest with something like this that you actually go in the overnight shift and do trainings with them and talk to them in person, because anybody calling about coronavirus at 2 a.m., there's probably going to be a pretty serious call. They're probably going to be very concerned. So they're going to be taking some difficult calls. Make sure they feel comfortable and that they know that you're there to support them. I want to talk about checking quality early and often. So even here, when we started taking coronavirus calls, The next day, just listening to some of those call recordings, I realized there's a problems right away. Looking at some of those text messages that were going out from people asking for text, people were not necessarily following the rules or protocols that we had put out. So making sure that we know people are under stress, they might be cutting corners, they might end up going off topic, really helping them to feel comfortable with the subject so that they can stay on topic and understand exactly what you want them to do, so that they are not collecting the data that you're going to need to do reporting later about, well, what was everybody calling about? What did they want? So if you have reasons for people to check off, like in our call report, we have the call type, but then all these different reasons. If somebody asks you about one of them, you can check multiple boxes. So if you have staff that are just checking one over and over again, you're not actually getting the data you're going to need later about what people are calling for. So really just watching that closely up front and then checking in often to make sure that people are collecting the data you're going to need later. Of course, going back to fix errors is terrible, but if you need to, and you see that you have staff that are not collecting the information you need, I do suggest having them go back and fix their errors. It will help them to not make those errors again in the future. Of course, having a stakeholder like a board member or somebody from, the board of supervisors or somebody from your county call in. And if you have I don't know if it's just me, but my karma gets me. If something bad is going to happen on a call and a specialist is going to say something you really didn't want them to say, it's always going to be some major stakeholder or somebody. So I just really want to warn you to check quality often, because when that board of supervisor person calls in and your specialist tells them something strange, it's really hard to explain later, even though it's only one call out of thousands that was not the way that you would have wanted to go. So just really check that out and watch quality closely. I think that might be my end of that, I think. Yeah, I said about the ports. I made all these notes of things to talk about. So the last thing I wanted to say about what I think is going to happen for us as far as going into the next few weeks. I think we're going to move quickly from this active kind of thing. I think it will escalate and we're going to have a bunch of stuff. But then after that, I think we're going to have a long recovery period. People calling in because they lost income, they all kinds of stuff. They end up losing their job because their business closed. Whatever it is, I think we're going to be going into a long-term recovery response that's going to last for a very long time. So similar to anybody else that's responded to a major disaster, fire, mudslide, hurricane, whatever, I do think there's going to be a major long-term recovery period coming for us soon.
I think you're right. So much, Kelly. And in light of time, we're going to hold off on questions until the very end and make sure we hear from our last two presenters. Thank you so much again, Kelly. You guys just know this in and out, and we can't thank you enough for being a part of our network. So we're going to turn the time over now to Damon Terzaghi from Advancing States, and he's going to talk to us about supporting our aging and people with disabilities communities, as we know that they've been affected disproportionately. Damon.
Great, thank you so very much. We do appreciate the opportunity to join today. For those of you not familiar with my organization, Advancing States is an association here in the DC area that represents all of the state government agencies that deliver aging, disability, and long-term services and supports. So really think about your state's Department of Aging, your state's Department of Disabilities, your state's Medicaid long-term services and supports agency. Those are our members, and that's the work that we do here in Washington to support their policy and programming. So I'm going to talk very briefly about what we've seen around the country in terms of services and supports and the response, and some of the implications for information and referral assistance programs, and really what y'all should be keeping an eye on as this issue progresses. So just very briefly, as Rachel mentioned earlier, this is a very significant issue to the aging and disabilities field. Older adults and those with underlying chronic conditions really do appear to be those at most risk for developing a serious health condition due to the virus. And I think that, the Washington state outbreak that's gotten so much attention over the past week and a half is really indicative of the worst case scenario. That was an outbreak that was concentrated in a nursing home where individuals live together and have close contact with each other and with staff. And those individuals were already, by definition, older and or had significant health conditions just by virtue of being in that nursing home. So that's something that we know is a topic of a lot of conversation, and the various health organizations, human services, long-term services, and supports organizations are paying close attention to ways to mitigate spread in those types of congregate living centers for older adults and people with disabilities. At a high level, we're really seeing that states are deferring to the CDC and really taking the lead, letting the CDC take the lead, and then working with in tandem with their state health departments to make the decisions on public safety. So much of the activity thus far has really been focused on disseminating accurate, timely, and quality information to both the individuals we serve, the older adults and people with disabilities, as well as to providers to really focus on ways to mitigate spread and identify instances where you might not want to have a provider enter into an individual's home or a setting or something like that. The other thing that we think is really important to raise is that, unfortunately, as occurs in many crises, there are already reports of scams surrounding the outbreak around the country, particularly those that target older adults. So we do just want to make sure that you're aware of that and able to help calm people down and provide them accurate information. Just one example that we've heard that was circulating even yesterday was older adults receiving calls from someone purporting to be with the CDC who was, providing some very dire information and then requesting personal information, credit card, social security information as ways to provide government assistance. So those types of scams are already out there, and it's worth paying attention to that and being prepared to provide some accurate corrections and help individuals not get subject to those types of exploitation. Some other issues we've seen are really those related to maintaining services. We are seeing instances where there are providers who have closed in preparation, but they've closed without notifying the states, or there are other issues where in-home providers are resistant to doing home visits for fear of either catching or spreading the disease. And there really does need to be a coordinated response between the providers, the state health, the state long-term services and supports agencies to ensure that necessary and critical services are maintained, but they're also responsive and flexible in relation to any outbreaks that may occur. So you may see up on the screen, if we go to the next slide, we as an association have created a website that you can visit by typing in that link there that gathers a lot of information from the various federal and state agencies that deliver services and supports to older adults and people with disabilities. This includes guidance around, some of the basic stuff we've already talked about, ways to mitigate spread and social distancing and just clean, healthy habits, as well as some more targeted directives, policy guidance, and operational memorandums around issues like nursing home practices or policies related to OAA services. So we do encourage you to both go take a look at what's up there if you're not familiar with what's happening in your state, as well as submit it to the email address that's on the website itself, because we're continually updating this. In fact, it's been updated several times this morning already. We've heard over and over that states and localities are clamoring for information, especially seeing what other states and organizations are doing to address the concerns. So moving forward, key issues we're seeing for states, first and foremost, is that states are really focused on flexibility in programming from the federal government, from HHS's Administration for Community Living and Centers for Medicare and Medicaid Services, to deliver services and supports in manners that really assure the health and safety of consumers, both in maintaining their access to the supports that they need, as well as in mitigating any potential further spread of the virus. So some examples of things that our states are telling us they're putting in place currently if they have an active outbreak, or developing contingency plans for in the event that it spreads to their locales, are things such as temporarily decentralizing congregate services. So think about like congregate meal programs for older adults, adult day services, group therapies, those sorts of services. They're looking at temporarily decentralizing them and providing them on a more individual basis, looking at establishing temporary rate structures for their long-term services and supports that allow for increased worker sick time, that provide access to telehealth services in lieu of services that would otherwise require a face-to-face visit, as well as increased nursing services in the home. We're also seeing states really looking to expand their surveillance so that they can better track the spread of instances and cases of the novel coronavirus within their aging and disability communities. And then we're also seeing states really looking at trying to expand the provider pool in case of a dire need. So for example, I talked earlier about temporarily decentralizing congregate services. If you're going to do that, your staffing ratios are going to change, because now you're going to have individuals going out to a person's home as opposed to having one individual in a congregate setting potentially serving multiple participants at once. So we are seeing states really looking at relaxing provider qualifications, potentially bringing in out-of-state providers from areas that don't have an active outbreak in order to deliver those services and supports. Then lastly, we're seeing attempts to extend timelines for certain functions that may not be as urgent during an active outbreak, things such as eligibility redeterminations for certain programs, things like grievances and appeals processes, as well as more long-term services and supports focused issues such as person-centered plans or pre-admission screening reviews, and what we call the minimum data set data collection in nursing homes, those sorts of processes that may not be quite as urgently related to health and welfare issues. We are seeing states look to extend those timelines so that they can be performed once the immediate community need declines a little bit. So a couple of key concerns that we do just want to highlight, first of all, is ensuring ongoing access to services. I have mentioned this a few times, but really that service providers and centers shouldn't be unilaterally closing or deciding not to deliver supports to individuals. It should really be a decision that's made collaboratively between the state aging, public health, disability, and agencies, as well as the local public health and providers themselves. Other key concerns are, at what point do states need to start moving towards decentralizing and temporarily dispersing those congregate services and supports? You know, this is kind of similar to what we heard earlier when San Jose and the surrounding areas are really trying to limit gatherings. I think that this is kind of a more nuanced and targeted version of that same conversation, which is, you know, at what point do we not do business as normal in order to mitigate further spread? Then other things such as like waiving nutritional requirements just to make sure people get adequate food sources that maybe don't meet the standard things, you know, maybe focusing a little bit more on frozen meals, and other sorts of things to keep a stock of food in a person's house if they're quarantined or if there's not sufficient staff to go out there every day and deliver, hot meals and those sorts of things. A couple of just considerations from the INR perspective. First and foremost is really stay in active conversation with both your state and local aging, disabilities, and long-term services and supports agencies. As we've seen both within our country and across the globe, this illness can spread pretty rapidly. So changes may occur suddenly based on evolving information that's available. Keep a specific eye out for changes in policy related to service delivery. If your state is potentially closing congregate meal sites, as an INR agency, you're going to want to know that when individuals are seeking alternate ways to access their needed resources. So really do just keep an eye out on what the agencies and both at the state and local level are doing around service delivery. And then also really keep tabs on unexpected closures. You guys are so close to the individuals we serve. If you're hearing reports of a program being closed, make sure that the state knows, because we have heard, as I mentioned earlier, we've heard instances where the state was unaware that a provider closed their doors and were not able to adequately respond to that. So just make sure that you're doing a bit of a feedback loop as well, so that the state's aware of what's happening in your communities and they can respond adequately if it's not what's supposed to be happening. Those are some really quick hit thoughts from our perspective. I do know that this webinar has gone pretty long, so I'm going to just stop there. And if there are specific questions y'all have, I'll stay on the line for a little bit to see if we can answer those as well.
Awesome. Thank you so much, Damon. And I hope everybody bookmarks that site. We are way over time right now, but I think everybody has felt this information has been incredibly relevant. I'm going to turn the time over to Alana to tie things up for a last comment, and then I think Rachel's going to make just a quick closing announcement at the end. So we'll turn the time over to Alana right now.
Thanks, Josh. So I'm going to be really brief because I know we're over time. So I'm just going to talk quickly about kind of how we in Connecticut have structured our information and our resource data, both for use by our contact specialists and also the public. And really, I think one of the key points is that this has been, sort of an evolving situation. So we started with one method of delivering information to our contact center staff and the public, about 2 months ago. So initially we had all the information in one FAQ style document that was listed in our resource database under one program. And that was sufficient for the first couple months. And last week, when we finalized our agreement with the State Department of Public Health to be the official information line for Connecticut regarding COVID questions, we quickly realized that the situation was escalating and we needed to structure it differently. And so now what we've done is we've created in our resource database a new agency record specific for COVID, and we have all of the frequently asked questions listed individually under that agency as their own programs. And so this has allowed us to do a couple things. So one, it is easy for our staff to be able to navigate this way. So instead of navigating through a long document, they're able to kind of browse that list of programs, find the particular question or topic that's relevant to the call they're on, open that up, and then read from the program description. It also allows them, when they're talking to callers, to isolate the particular sort of snippet of relevant information and send that to the caller via email or text, so that we're sharing that information with individual callers. And that's particularly important in this scenario because what we've done is we've embedded a lot of the relevant web links into those program descriptions because one of our challenges right now is trying to find a balance where we're giving staff enough language to use when they're answering questions, but also that we're linking to source data where we can so that we have less information to keep updated. And so, we've then been instructing our staff to use those web links that we've embedded in the various FAQs to get additional pieces of information to share with callers. And then if we're sharing that whole sort of program resource record via text or via email with a caller, they then have that direct web link at their fingertips to click on and get more information. So for example, places where we're doing this, instead of keeping the list updated ourselves on what countries are level 2 or level 3 countries right now, right? We're just linking to that particular page on the CDC website because that information is constantly changing. So every time a contact specialist gets that question, they open up the program description, they read a little bit of text, like a little bit of scripting, and then they click on the CDC link to view which countries are level 2 and level 3 right now. Same thing with case counts that are in other states. We have questions coming in all the time now about how many cases are in Washington State. I'm supposed to travel there next week. How many cases are in Florida? I'm supposed to travel there. So again, having those relevant links embedded in the particular FAQ so that our contact specialists can click and find that those additional details. So I guess the only other things I would add is that having the information organized like this, so by sort of topic or FAQ, also allows us, like Kelly was talking about earlier, to do easy reporting to the state. We just run a report every day of the number of referrals to each program. One call can have multiple referrals if folks have multiple questions. So it's easy reporting. And we did get scripting from our State Department of Public Health on sort of 7 FAQs. And so we have that scripting in those 7 particular FAQs, but clearly that hasn't been enough in order for our staff to answer all the questions, varied questions that they're getting. So we've had to add about 20 additional FAQs ourselves, which we weren't provided scripting from the state for. So we're just using all of the resources that we have available to us to come up with the language and the scripting for those additional FAQs. So we've had to add one on, is it safe to open mail and packaging from affected countries, right? Is it, what's the status of school closures, those sorts of things. And so we come up with that scripting right now based on any feedback we can get from our state public health officials, through two-way conversation and escalating questions to them. We get it from all the official press releases and guidance that is being released as we comb through that, and then from other trusted, legitimate sources, particularly the CDC, of course, and then also the World Health Organization and the State Department. So if anybody's interested in how we kind of, in the sort of FAQ structure we have right now and in the scripting that we have embedded in each of those, you can go to our website, 211ct.org, and search coronavirus, and you'll see that the whole list of about 25 FAQs comes up, and you can kind of scroll through those and click on any of them. And then I would say the other ongoing challenge right now is keeping that list of FAQs to a size that's manageable for our staff to navigate. And so we've been adding new FAQs, new topics almost daily at this point. So then we're also trying really hard to review that list every day and make FAQ questions or topics inactive, ones that may no longer be relevant. So we may have had a question 4 days ago that was very relevant, and we added scripting about it, and now nobody's asking about it. And so let's make that inactive so that we can, keep this list to a manageable size, because if we end up with 70 FAQs, nobody's going to be able to navigate that. So that's just an ongoing challenge and something that we're struggling with right now, but very aware of. And then also, I think, there's a little bit of sensitivity right now for us, because the FAQs that we are putting into our resource database are for use by our staff, but they're also publicly available on our website. So making sure that we're using language that's appropriate for our contact center staff to be using and reading as scripting, but is also appropriate to anybody from the public that finds it on our website. So I think I'll pause there because I know we're already over time, but I hope those are a couple things and considerations that are helpful to others as they're figuring out how to structure all this information in their resource databases.
Beautiful. Thank you so much, Alana. And I'm going to turn the time over to Kiara to kind of wrap things up. I think she's got, we'll also see if Rachel has a moment here to finalize things. I know we're all like racing to your website right now, Alana. You guys do such a fantastic job there. So Kiara, back to you.
All right, I'll go ahead and take that back. Can you guys hear me okay?
Yes.
Okay, I'll go ahead and take that back. Rachel, while I'm doing that, do you have anything you want to add lastly?
Can you hear me okay?
Yes.
Awesome. The only thing I want to add, I think there's been some chatter in the chat probably during this call about news alerts that everyone just conveniently received. So the World Health Organization, WHO, did just make an announcement that they're declaring COVID-19 a pandemic. Specifically, up until now, they had only referred to it as an epidemic. Those are different things. So I just want to clarify for folks, a pandemic refers specifically to the spread and transmission of a novel virus. So the declaration of a pandemic mostly reflects the fact that there are cases in over 100 countries, that it is spreading, all the things we already know and talked about on this call. It essentially helps galvanize resources in many countries to take more mitigation and preventive measures. But declaring something a pandemic does not necessarily relate to the severity of the virus itself. So I don't want anyone to see that announcement and then think, oh my God, suddenly it's more fatal than we thought, or it's more severe than we thought. This is essentially a declaration of the fact that it is spreading, which we knew. There will be lots of more information, but the other thing I will say is, while I can say this to all of you and local health officials can scream it from the mountaintops, the word pandemic will probably cause more panic in the general public. It will probably be something that gets blown out of proportion potentially by our media friends in many cases. So I would definitely just recommend starting to really think about using the tools and best practices from this webinar and what you already know to start mitigating call volume, because that may start to really increase purely because of word of mouth.
That's very true. So something that we want to do, so that is the end of the bulk of our conversation. As far as content, we have information that we're going to be gathering that will be being housed both in the work group that Rachel talked about, but also we'll be creating a page on the AIRS Learn site that will become an educational page where people can also access this. So there's some cross referencing there. Several of the panelists are going to stay around for a few minutes. There's a couple of other questions that have come up that I want to throw out there for them. So those are the panelists who need to go can. I know that there was a mention like Damon staying, Kelly staying. So we'll keep talking for a few minutes since we have this open already, but the bulk of this content is already there. You'll be receiving an email within an hour about then, and some more information as we have that available. So the other question that we had that came up kind of at the beginning was from Laura, and Damon, or might be the first person to answer this, or maybe others, but we're getting calls from families upset at nursing home lockdowns and wondering how they can ensure their family members are safe. Wondering if there's a consistent message to communicate regarding lockdowns.
Yeah, that is a great question. And I know that that's been an area where there's been a lot of deliberation around, because it obviously is a pretty significant step to take. I think that in terms of clear and consistent messaging, what we have heard from the states and what we would encourage is to really assure people, first of all, that this is a time-limited response. You know, a lockdown is not intended to be a long-term strategy. It's more of an immediate risk mitigation strategy. Second is that, you know, when we've seen lockdowns, like even in Washington state, that doesn't necessarily mean that they don't allow for any outside visitors at all. It just means that there are strict protocol put in place to make sure that no participants entering the building are ill or actively carrying the virus, as well as to just make sure that they're really limiting the number and frequency of visits, as well as being able to monitor and manage who's coming in and out at any given time. So I think those are kind of messages. I don't know how much it's going to really assuage someone who is currently in a panic because they're worried about their loved one who's in the nursing home and they're not sure how to learn about that specific individual. But, at the end of the day, it really is focused on mitigating spread of virus, as well as ensuring that the nursing home is able to deliver the most effective and most necessary care to the participants that are there. So
Is
that's
there,
kind of the.
is there a legal obligation for is there a legal obligation for a nursing home to let family members know if there is a positive case in that facility?
One of the things that actually has been very, very challenging about this outbreak is that it's kind of been bumping into HIPAA privacy related issues as well, right? Like, you want public information out there, but you also don't want to be relaying an individual's health information publicly. And so I would say that, each state is really working hard with their public health departments, with their PR departments, and with the providers themselves to really make sure that they're appropriately towing that line between what's needed to share and what's needed to ensure privacy of residents.
So another question is, and I'm going to have this go first to Damon and then possibly over to Kelly. For any services as we're taking these in, is there different information that we should be collecting from callers and clients as we assess them for services? Should we be adding more demographics that we're asking, or should we be minimizing those to just fewer? So Damon, do you want to go first and then we'll go to Kelly?
Yeah, I think that I wouldn't necessarily change it when you're talking about specific service-related issues. If you're thinking in terms of doing a screen for like what programs might they be eligible for and what services might they need. The changes that we are seeing are really focused a little bit more on individualizing the interventions, as well as relaxing some of the administrative protocol that might slow down the provision of services. I mean, at the end of the day, there might be some loosening of eligibility criteria, but we don't necessarily expect that to be wholesale, particularly in the aging and disability side of things. But I think that from my perspective, the actual information collection and screening for services would likely remain fairly similar to what it is now, but I'll let others answer that for non-aging programs.
Here in California, for right now, we're limiting the data collection that we're getting to the reasons or the questions, just collecting the reason that the person is calling, if they're asking us about what to do if they're sick, or if schools are closed, or what a mass gathering is, and things like that. Just keeping information and tracking what people are calling us about so that we can report that to the public health department every morning. So we are keeping the data collection pretty tight right now so that we can get through the calls. If we were asked to ask callers' age or something like that, then we could expand if public health wanted us to ask additional questions. But what we always have is the caller's phone number and zip code, at least, so we know in zip codes what questions are coming up. So we could, report out to public health about where the questions are actually coming from, if there's pockets of people that are concerned about particular issues.
Okay, I also a question that has come up is actually, Clive, I want to prepare you. I think you're still there. I'm going to volley this to you. There's actually two questions. So one is a question about a COVID-19 target term or a taxonomy term. What do you know about that?
There's two taxonomy terms that were approved and introduced in the taxonomy about three weeks ago. We had the conversations with both Wellski and iCarol regarding getting those into the systems and being updated, and both those softwares have agreed to do that. And if it's not already in place, it should be in place within a day or so. Other softwares, you should be able to do your own update and introduce those terms. And so you'd be able to sort of tag automatically the calls relating to COVID-19.
Do you happen to know what the term is?
It has both of them have the word COVID-19. I think
okay.
One might
so
be
just
COVID-19.
COVID-19.
One might be treatment. So it's usually how it goes.
Okay. So another question is, from your perspective, from that AIR's perspective, who are supporting both advancing, aging and disability 2-in-1's general types of information and referral, what is the importance that as AIR's members and as a network that we're putting forth kind of a consistent message around, it's a pandemic, but don't panic, and what we're telling people how to behave and what to do. What are your thoughts on that?
I think it's been said already. I think we, have to use the CDC website as our go-to. Tell people that, from the CDC website, I am quoting them, regard this and this and this. And we're not medical professionals. We have to stress that. But there might be circumstances where we might strongly suggest to somebody that they give their clinic a call or give their doctor's office a call. Mostly, I would say, be brave. We've got folks on this call who are extraordinarily experienced and capable of handling all sorts of events. So there might be a lot of folks on the call who are thinking, I can't do that, or that seems too much, or my organization might feel uncomfortable about that. But it's think about what you can do and do that. Even just putting information on your IVR, and if you don't have text, there's ways of getting information out there. We all have distinct client groups, and many of those client groups are very vulnerable in the situations. Think of what you can do it.
Well, and actually something that came up today is my parents have been living in Italy for almost 2 years and came back earlier than they'd planned in order to get back into the United States, but they've been keeping up on the news in Italy. And one of the things that they said that their prime minister said was, we need to behave in a way that protects the most vulnerable of us. So maybe you yourself aren't in a high risk group, but there are people who are at higher risk of this disease and the impact that it could have on them. And so caution is always a good thing. I think we are out of questions, and we have a few things that we'll be posting again. Clive, any last words before we wrap this up?
No, I'll defer to Rachel if there's any other summary.
Okay. Rachel, anything for you?
Just a big thank you, and that we and the AIRS team are all here to support and help however we can.
All right. You guys are great. Thanks for sticking with us. Those 400 of you who stayed the whole time, we'll get that information out to you as soon as we can. Good luck. Have a great day.
Good job.